Okay, and I think we're actually on here. And I was sitting here doodling while we were waiting. But welcome to PerfWeb 16. Can you believe this is the 16th live webinar episode that we are broadcasting? And we got a great show for you tonight. But before we start, a couple of things that are going to be very important. Need you, if you're watching on Facebook, just so you know, I'm only monitoring the YouTube chat. I can't monitor both the YouTube chat and Facebook. So if you want to talk to me, you want to communicate, try to do it through the YouTube chat if you don't mind. That makes things a lot easier for me. Also, and to do that, you have to have a Gmail account. So if you'll get one of those, make sure you have a Gmail account, make sure you are logged in, and on top of that, once you get logged in, click the subscribe button and the notification button, which is that green bell that you see right there. So make sure you do those things for me, please. In addition, if you go to our website, perfweb.us, you know that you can download one of our flyers, which I think, look, I think the flyer's cute. I created the flyer and I personally like it, okay? It's one of my favorites. So I enjoyed making it and I actually still enjoy reading this crazy thing. But you can download them and share them with your friends, would be most appreciated. In fact, I'd like you to share this on Facebook, share this on YouTube, share this by email, whatever you want to do. We're really trying to build our community and continue to grow the participation in each of these. If you want to do the YouTube chat, you can. I will monitor it and respond to these things. However, if you'd prefer to call in, which is always great for us because then we have this dialogue back and forth, the phone number to call in is somewhere around here. It'll show up here in just a second. And there it is. Oh, with Facebook, okay, so it's covered by Facebook. Got to get Facebook out of there first. Let's try that again. Hold on. There it is, 281-738-7906. And I've got the phone right here. We're going to go ahead and we'll give you a notification that'll say the phone lines are open, and that's what you'll see. It'll say phone lines open and the telephone number. So wait until you see that for today's program, if you don't mind, and then we can have open discussion back and forth, especially in lieu of Hurricane Florence bearing down right now on North Carolina. Look, they're in serious trouble. And my second part of this presentation is really going to do a lot about disasters and perfusion, or a healthcare professional as a whole. So I think it's going to be an interesting program, and appreciate you all participating. Now I want to introduce, before I give my... What happened there? I'm listening to myself. Now I want to introduce, before I can you turn yours down for a second, Nate? Yeah.
I don't even know how.
No, just turn the feed down. The YouTube. Yeah. And can you center the camera for me? See, I'm off. The YouTube. And can you center the camera for me? There you go. Great. Whew. There, now we're there. Okay. So I'd like to introduce, thank you, Nate. Nate Badair, you saw him last week. He was on the program, and that was a... Thank you, Nate. Nate Badair, you saw him last week. He was on the program. Nate, you have to turn your YouTube off, bud. Your YouTube. Nate, you have to turn your YouTube off, bud. Okay, I think we're there. Good. Okay, I do. I think we're there now. Okay. So now we're in good shape. Nate wanted to watch himself on YouTube. So I do. I think we're there now. Okay. So now we're in good shape. Nate wanted so anyway, let's fix it with Nate. Cut him. I'm going to go straight to the slides. So let's go to the slides. So anyway, let's fix it with Nate. Cut him. I'm going to go straight to the slides. Perfect. So let's go to the slides. All right. So pump standby, when and how. So what do we do pump standby for? We do it for OpCab, we do it for Tavor, we do it for pericardial windows, we do it for convergent procedures, we do it for lead extractions, and we do it for Watchman procedures. So we do it pump standby for a whole bunch of different things. the real question is, how do we do pump standby? And I think there's huge variation across the board with how we are all doing this. I want to illustrate some of that with some of these next slides. So, and I need to look at my computer at the same time because the text is rather small. But let's read this. This is very interesting. Development of our Tavor, or they call it Tabby. And just so you know, Tavi and Tavor are the exact same thing. The reason that they call it Tavor here in the United States and Tavi in Europe is because here in the United States, you cannot be reimbursed or paid by CMS for an implant, but you can for a replacement. So if for us, it's transaortic, transfemoral or whatever, aortic valve replacement versus aortic valve implant. That's why that is. But all transcatheter aortic valve implantations or replacements cases are done in our hybrid operating room with a multidisciplinary approach and a primed cardiopulmonary bypass circuit on pump standby. Now, one would think that that's always the case. We decided that we would resuscitate all patients undergoing Tavi procedure via a transfemoral, transapical, or transthoracic approach, transaortic approach, if required. Perfusion plays an essential role in providing rescue CPB for patient salvage when catastrophic complications occur. To coordinate the multidisciplinary effort, we have developed a written safety checklist that assigns a predetermined role for team members for the rapid sequence initiation of CPB. Although many Tavi patients are not candidates for conventional aortic valve replacements, we feel strongly that rescue CPB should be offered to all Tavi patients to allow the correction of potentially reversible complications. Now, they might go into VFib. In fact, that happened to me today. The protocol is included in every surgical timeout involving Tavi and Tavi procedure. The protocol has led to rapid and safe CPB initiation in less than 5 minutes of cardiac arrest. It has also led to coordinated and consistent team with pre-specific roles and improved communication. Now look, that was a whole lot of verbiage, but what they're saying is they have the pump in the room, primed, and a perfusionist on standby actually as part of the actual team that's performing the procedure. And even with that, it takes 5 minutes, and if the patient, of course, is in VFib, then they're being resuscitated for those 5 minutes. Hopefully the resuscitation is good or the CPR is effective, but that still takes 5 minutes. And I think that's probably being pretty generous to themselves, at least that's my thought, because I've been in these circumstances before, as many of you also have. So they go on to discuss these carrots and the merits of the protocol and so forth. But what I found was this survey that was done. And when you look at this survey on perfusion coverage for Tavor procedures, I'm going to go through the entire survey. But if you look at it, number one, centers performing Tavor commonly have case volumes greater than 400 CPBs per year. The average program performs between 20 and 50 Tavors per year, and some centers doing over 100 Tavors per year. Most procedures are performed in a hybrid room, and it goes on to explain these various things. But this is a very interesting study that was, or survey that was done by Cardiology Review in 2013. And let's go through each of these slides. See, I'm not switching the thing. And this is the study that I'm talking about here. Okay, so let's go through that first slide. So this is where it was published, and you can see that on there. And now we'll go through the first slide. What is your total cardiac surgery volume? In the choices, greater than 1,000 cases with 34% of the respondents. And if you look down here, you can see that the total respondents was about 100, okay? Or was 100, I should say. Doing between 750 and 1,000 was 11%, between 400 and 750, 35%, and between 200 and 400, 17%. Less than 200 was only 3% of the total respondents of this particular survey. And then going to the next slide here, it asked which best describes the circuit you use for Tabby procedures. What I found interesting was full circuit with suckers, cardioplegia, and heater cooler. In other words, the full cardiopulmonary bypass circuit was 87%. Mini circuit, like having an ECMO, which is what I was using today, is only 3%, and a modified circuit with small heater cooler and modified suction and cardioplegia was 10%. Now, I don't know what, I guess that's just a mini bypass circuit. Maybe they used a smaller machine that only had, 2 roller pumps and a centrifugal, so kind of like a bigger ECMO, but a smaller heart-lung machine. That's what I'm assuming that is there. Do you prime your pump? So of the respondents, there were 99 respondents, so somebody didn't respond to this one. 79, almost 80% responded that they in fact do prime their pump. And in this study, 20% said that they did not. Now, of course, we all are going to ask, as soon as I saw this slide, I said, well, I had a follow-up question to it, but don't worry, they asked too. I thought that was interesting. Do you reuse your primed standby pump? So you didn't use it for the Tavor. Do you use it for the next Tavor? Or do you use it for a heart case, or whatever the situation may be? Which begs the question in my mind anyway. In fact, let's bring Nate in. Hopefully we got that technical issue resolved. So let's bring Nate in and adjust the camera. There you go, so I'm not half cut off. Hey, everybody. Hey, Nate, okay, you got the YouTube turned down, bud? Nope, now I can't hear him at all. It's just all going to heck in a handbasket here.
Joe, can you hear me?
Yes, I got you. Yes. Good. Okay. We're good.
Okay.
So here's a good question that I like. So this is Nate Badair. He was on the program last week. Nate, it's great to see you. Thank you so much for doing this.
For having me.
So we're talking, I'm assuming you heard my beginning of this thing and my talk, and we're discussing whether you reuse your pump. How long, if the pump is primed, do your hospitals allow you to reuse it if you want to, once it's primed?
3 to 5 days.
3 to 5 days. And what is that based on?
Sorry, go ahead.
What is that based on?
Just what the protocol, what the people who were there before me did. No, nothing other than that. I mean, I know there's some tests that show after a certain amount of time, or some studies that show after a certain amount of time, there's some issues with infection, not an infection, but bacterial colonization. But other than that, and I've seen the studies, but I couldn't tell you what they were. It's been a while. Mm-hmm. Other than that, that's what people did. Mm-hmm, mm-hmm, mm-hmm.
Yeah, it's a good question. I don't know the answer. I'm sure that there's probably across the board. I've seen people who have said once it's primed, tear it down. I'm curious what any colleagues of ours may think. I'd love for them to respond either on the YouTube chat or call in. I've seen, you know what, it's one patient and you're done. I've seen 1 day. I've seen if you use it tomorrow morning. I've seen 3 to 5 days. I've seen as long as a week. And I've seen a few times where it's actually been longer than that.
I have heard that as well. I know we have a colleague that we work with at another facility that even a dry setup, when she's done with it, she's done with it. She destroys, not destroys, she tears it down and throws it away.
Uh-huh.
Whether she primed or not. And that's just the way she's always done it. Where one of the facilities I used to work at, we set it up and it was good for a month.
Mm-hmm. A month.
A month.
Well, and I've seen that with the old Centromag, the Well, it used to be Thoratec. I guess it's Abbott now. And I've seen on the them having that up for 28 days, and then at 28 days they tear it down and put another one up. And those things are, if they didn't use it, those things are 25 grand a pop. You know,
That's probably,
I mean,
that's probably why. To be honest with you,
say that again.
that's probably why.
That they don't tear it down for 28 days.
Because of cost.
Yeah, I agree. But, you know, is there a way? I mean, I don't know. It's interesting. It's an interesting problem. But anyway, let me go on to the next slide if I can. We're going to cut you out for a minute, Nate. I'm going to go on to the next slide.
Yeah.
So on this slide, oh, can you, that's good. Where do you perform Tavor and Tavi procedures? And this is another good one here. Cardiac cath lab was 21%. The hybrid room was 66%, so most people are clearly using hybrid rooms. The cardiac operating room was only 1%, and then in multiple sites was 12%. So I would assume that would be the cath lab and the hybrid room. So I thought that was fairly interesting. And then coming over here to this slide, it's asking how often do you go on bypass for Tavor or Tavi? Now that's another really good question. How often are you using it? Well, almost never, which was 0 to 2% of the time, interestingly was 64% of the responses. Rarely, 2 to 4% was 27% of the time. Sometimes 5 to 10% was 6%, and more often than 10% was 3% of the time. So rarely and almost never really dominated this. So let's go back and bring Nate back in, because these are some really good points. So Nate, based on that information, you know, when you look at the preliminary comments that I made that were written, where they said that they put every patient who has a problem on some type of support to see if they can correct the problem. And this was something I feel was an issue some years ago when we discussed this. We would say, well, if the patient isn't a surgical candidate, now in their case, they said that they had some patients that were not surgical candidates, but they still put them on Tavor, or they still put them on bypass of whatever form, ECMO or whatever it was, to support them to see if they could correct the problem. But if they're not surgical candidates, other than that, you know, wasn't that the argument? What are we doing this? What are we even here for? Why are we even here? Have you not heard that before? Why is the perfusionist even involved if we're not going to take this patient to the operating room to correct the problem?
Yes. But at the same time, it is a hybrid unit. That's the whole point of it, right? It's a hybrid room.
Mm-hmm.
That's the whole point of having a hybrid room, so you could have the perfusionist in there while they're using the other equipment at the same time, or the whole surgical staff in there, whether also it's half cath lab too.
Right, but how do you address the issue of we're doing Tavors on people as essentially palliative care, and then the patient has a problem, and now you put the patient on ECMO, and you can't correct the problem, but the patient's not a surgical candidate, and now you have a patient on ECMO. When do you turn that off? Who turns that off? What's the ethical considerations that go along with that as a problem? I mean, how are you going to address that with the family? We put them on mechanical support.
And you and I both know, and everybody out there listening knows that comes down to what the surgeon wants. We, many times, unfortunately, we run ECMOs on patients that we are pretty sure have no chance to survive any longer. Mm-hmm. But what do? We keep working as long as the surgeon says you have to keep working. Ethically, at some point, I'd like to think we have a say as perfusionists, but beyond just telling the surgeon, hey, I don't really think there's a good outcome in this situation, I don't think we have much say in the final scheme of things. And mm-hmm. Some surgeons take that into account more than others. Some surgeons just, in my experience, just say, oh, okay, and they ignore it. And other surgeons will take that into consideration, and as they move forward.
Mm-hmm. Mm-hmm. That's good. Okay, that's a really good point. Okay, so let's go back to my slides again, please. So this next slide asks, how many Tavors procedure does your center do? 0 to 20 per year was 20%. 21 to 50 was 37%. 51 to 100 was 24.5% or 24.7%, and greater than 100 was 18.56%. Again, only 97 people responded, so 3 centers didn't respond, or 3 people didn't respond to this particular survey. Look, I can tell you right now, where I was at today, they did 4 Tavors today. They do in the neighborhood of 360 Tavors a year. So there are some places who are doing a lot. They clearly didn't respond to this particular survey, but there are some very high volume Tavor programs, which surprises me because, I never saw that many AVRs in my entire career. So I'm kind of surprised by that number, to be frank with you. But this is another good one. Which statement best describes your outlook of Tavor? So let's just go to the dominant one. 42%, that's down at the bottom. It is too early to tell how these procedures will make a difference. The next highest is these procedures will have greater application in the future and reduce pump surgery volume. And then at 17%, that was the second one, then these procedures will add more opportunities for perfusionists. 17% felt that these procedures will add more opportunities for perfusionists. I don't know how, but that's fine. 9% said these procedures will have limited application and not affect pump surgery volume. I tend to be in that category. Let's bring Nate back in now. Nate, what do you think of those? Do you have any ideas?
Where we work, we're kind of more community centers. We don't do Tavors at this point that I'm aware of. So for us, it doesn't affect us. I think in future it will. I've heard many times that these type of devices will eliminate pump surgery for valves in the future. But I think that's a fallacy, because what happens when they poke a hole in the ventricle? What happens when the valve pops off the stem?
What are you going to do? What are you going to do?
We're going to go on pump. We're going to fix that.
How are you going to fix that? How are you going to go fish it out? Where are you going to find it?
I don't know, but they're going to have to do it, and I think it's going to require perfusion support to do so.
Yeah, I don't know, man. I don't know. I would think if something like that happened, it would be, especially on a patient. I mean, unless this is going to move into the very low risk. Look, I'm just going to ask you a point blank question, and I'll ask myself the same question. I'll even ask myself first. Okay. Would you have, so I'll answer just like I was asking myself. Would you have open AVR if you had just isolated, idiopathic calcific aortic stenosis? Would you have AVR or would you have a Tavor? If it were me, I would have an open AVR. I would have them do like a the parasternotomy, the minimally invasive technique, and just open it up and use that like that Percival valve, or the one that Edwards has one similar, where it's the sutureless valve. They put it into 3. We've seen Matoyer do those. They put in the stitches, 3 stitches, put it down, inflate it, tie those 3 stitches down, and they're out. Yeah, and it's a very short pump run, very short clamp time, and it seems to, they don't have to do as much debridement, and they seem to have really good outcomes with it. So for me, I'm a relatively low surgical risk. I'd rather have that done than have a Tavor. What say you?
I feel the same way. At this point in time, if in the situation we're discussing, then yes, that's exactly how I would do it. Now, having said that, just say I had a cab tomorrow, and then 10 years from now or 5 years from now, I needed a valve, and the surgeon, it's the same surgeon, but he's been doing Tavors now, and he comes to me and says, "Hey, this is safer because of your previous history." I'd probably consider a Tavor at that point. But just for an isolated, if I need a valve tomorrow, Yep, I'm calling Matoyer, Vanny, Duvall, one of those guys, saying, hey, when can you fit me in? I want you to do it on pump, open.
Well, if it's Patrick, I'm not calling one of those guys. I know who I'm calling, and it's not. You know who it is too, but I can't say it. Okay, so let's. I'm curious, of course, again, if our audience has an opinion about that, I'd love to hear about it. We can even open the phone lines here anytime. So if you want to do that, and let's switch back to my slides again. Let me go through the rest of these. And then what are your responsibilities for Tavor or Tavi standby coverage? This was very good too. So just standing by for pump was 100%. But 43% did intra-aortic balloon pump monitoring. 26% did setup monitoring, which I don't know what that is. And 22% did Tavor procedure checklist. And 0% prepared the valve, thankfully, because I don't think that's really within our scope or in our purview. But nevertheless, they asked the question. Maybe that's where the new opportunities for perfusionists come in. We can be preparing the valve. Oh, here, I forgot to change the slide. Okay, there's the slide. Stand by for, I keep changing it I forget to change it in the second place. Stand by for pump, there you can see it right there. Setup monitoring, intra-aortic balloon pump, Tavor procedure checklist, and then preparing the valve. So going to the next slide here. Okay, now, take a look at that. Everybody, I want everybody who's watching to take a real good look at that. See that great big mass going back and forth from the right atrium to the right ventricle? Okay, so bring Nate back in. And can you have both Nate and I and the slides?
You can minimize me, it's okay.
No, we'll keep you on there. This is Nate's case. No, can't do it? Okay, so just go ahead and take Nate away for a second. So let me tell y'all, just for a second, Nate, you'll come back.
Yes.
So this is what they saw on the echo. Now what happened was that thing that you see there disappeared. It just disappeared. You see it, and then it was gone.
Of course.
Miss, are you telling us absolutely everything?
Not exactly. We're also out of coffee.
Don't panic. Don't panic.
Listen to me. Your crew is in complete control of the
Yep,
situation.
it only takes 5 minutes to set the pump up or less.
Absolutely nothing to worry about.
No concern at all. We're here. So really, you can bring Nate back and you can take my slides away. So Nate,
Yes, sir.
it isn't just Tavor's. I thought those slides on Tavor were important to show, but really we do standby for so many different things.
Yes, sir.
And that thing that you saw in the atrium there didn't originate back in the atrium going back and forth before it disappeared. It originated all the way down in the kidney. That was a renal cell carcinoma, right?
Right.
And we were kind of there on pump standby, but we didn't have the pump primed.
We didn't have a pump in the room because we didn't know what we were dealing with, unfortunately.
Mm-hmm. So what was it like?
We were told cell saver standby. He told me, the surgeon informed me that he would like us there in case it was a bad bleed situation.
Okay.
Cell saver was what we were expecting. That was in the room. We weren't in the main heart room, which in the future with these type of cases, we will be, or I will pitch a fit. I think we will be with this particular surgeon. I don't think that'll happen again.
Mm-hmm.
It wasn't primed. There was no heater cooler. There were no cannulas. There was nothing, Joe. And yes, that's on me to some extent, but I honestly had no knowledge of the extent of the issue we were dealing with. After speaking to you, which you probably have a slide on this.
No, I don't. That was my last slide.
Okay, well, after
That was
speaking
my
to you,
last
those
slide.
Cases, renal cell carcinoma tend to go bad and go bad quickly. And there will be a pump standby if I'm there in the future. It will be primed and ready to go. And if I can talk the surgeon into it, I'll have the lines on the table.
So just so I'm clear, they actually didn't even want pump standby. They just wanted cell saver standby in case they started bleeding.
That's
And then-
exactly that's what I understood.
And then all hell broke loose.
Yes. Of course, we found out later, seeing the TE, that a chunk of the tumor broke off, shot up down the into the right atrium, into the ventricle, and then the vena cava just fell apart on us. And
But that
literally
big
my
chunk
warning-
ended up in the PA, right?
Yes, sir. My warning was, we might have to go on pump. We're going on pump, and it was quite literally that quick.
Mm-hmm.
When he said we might have to go on pump, I started moving to the door because we have a core that we walk through to get to our main heart room. And I heard him say, we're going to have to go on pump before the door shut behind me.
Mm-hmm.
So it was less than 10 seconds between the words, we might have to go on pump, and we're going on pump. And we were probably on pump in under 5 minutes.
That's pretty good.
But my heart rate was elevated. I was sweaty. We were all sweaty. I was yelling at nurses, not in a mean way, but get this, get that. It's just it was a bad situation. It should have been, we should have had the pump primed and in the room at minimum.
Yeah.
Because and I don't know, what's the rough cost of a pump circuit versus a patient passing?
It's minuscule. It's nominal. It's insignificant when you look at the overall thing. But this is where you start getting into these other issues. Is you set the pump up, you prime it, you're ready for the standby, you don't use it 90+% of the time. Do you throw it away and set another one up for the next patient, or do you leave it and reuse it?
I think in most of our practice, we tend to reuse it.
Mm-hmm.
Of course, we're not passing lines off. It's for op cabs and things like that. And even then, now, most of our surgeons, if they're doing an op cab, they don't want us priming. One surgeon in particular will have your hide if he catches you priming. So the key there is to prime beforehand and don't say
Mm-hmm.
anything. But
Mm-hmm.
so we tend to set it up, leave it for a week. We have discussed it with the manager, Stephanie, and her plan in general is you send her a note and it's tore down within 5 to 7 days if it's not used.
So that's our policy on that.
That's our particular policy.
Okay. So now, of course, I take this a step further. You're doing do you set a pump up for a convergent procedure?
Such as?
The convergent procedure, where they do that atrial fib, where they go up to the cath lab and they snake a cath. It's some kind of burning unit. No, the Watchman is the left atrial appendage ablation.
I've never had them call me for a setup for that. I've never even had them tell me we were standing by for that.
Mm-hmm.
I have for atrial leads, but in general, we didn't set it up for atrial lead removals either.
Mm-hmm.
We were just in the house.
Mm-hmm.
The idea is most of the time those aren't where I worked before. We were doing standbys. Those weren't done in the cath lab,
Mm-hmm.
not in a room. So the reasoning was, and it's poor reasoning, but this is their thought. If something bad happens, the perfusionist has time to prime,
Mm-hmm.
get ready to get on pump before the patient's even in the room. But like I said, that's poor. In my opinion, that's poor reasoning. If we're doing this and we have hybrid rooms, and you're already charging for a standby for perfusion, what's the additional cost of a pump circuit relative to the charge for pump standby?
It's minimal, and frankly, I think that if you're doing an op cab, the way I feel about it is I think the lines, because when is something going to go wrong? Something's always going to go wrong when you absolutely have to have something. So we don't drop the lines on the table off the table very often. We don't drop the lines on the floor and contaminate them very often. But
Right.
if it's going to happen, it's going to happen during an emergency.
Yes,
So I am wondering whether or not we should not prime the pump and have the lines on the field on any of these procedures and have them there and ready so that we don't have to, in a hurry, prime it, get the lines up, everybody's frantic. The chances of something happening at that moment, now you have to make a choice. Do I use the contaminated circuit or do I wait and continue to do whatever it is that I'm doing, which is suboptimal anyway? It's rescue therapy. It's certainly, resuscitation is effective, but if you have to set something back up again, that's going to take quite a bit of time. If you just have to cut a line and add a piece to it, now you're running the risk of air. Anything can happen, and it's always a crisis. And I don't understand if it wouldn't make more sense to just have everything up on the line. And again, I'm curious what other people may think. If somebody wants to call in and give their opinion, it'd be great. Make a YouTube chat, be great. But I really am curious what other people do as far as standbys are concerned. I think if we're pump standby and you're in an operating room and there's a pump in the room, I think at the very least, it should be fully primed. I think if it's fully primed, I think the line should be at the table. You take it away, you tear it down, that patient bought it, whatever, CMS is paying for that patient, it's part of the DRG, whatever it is, it's just that's where it got used. You set another one up for the next patient. That's what I think.
Some surgeons, I don't think we would have any issue at all with some of our surgeons getting them to agree to that. But one in particular, who's the most prolific off-pump surgeon we work with, I don't know if you want me to say names or not. So
no.
I'm trying to he doesn't even want us to prime the pump.
Mm-hmm.
He has yelled at one of our perfusionists before, who laughs about it. He's not offended, but the perfusionist laughs about it and says, "Yeah, but it's my license on the line. It's I'm the one. If I'm not ready, it's my fault."
Right.
So I agree with you to a good extent, but it's convincing the surgeons. And even then, if we start doing it, it's also convincing administration in the facilities when they come to us and say, "Hey, why are the costs going up? Why are we ordering more? Why are we ordering more pump packs? What's going on here?"
Mm-hmm.
Then we have to go and convince them this is a safety issue. This is a patient care issue. And I don't know. I think we need a broader response. A study might not be what we need, but we might need something that severe to say this is a standard of care, or maybe we should go. Organizations should be pushing that as a standard of care.
Yeah, maybe STS should.
Yeah.
What's STS say? They say something about everything else. Why don't they say something about this too? What is the appropriate way to do a pump standby? Maybe if that was a question, I don't know. I mean, I know it's rare, and I know it seems wasteful, and I do understand. I'm not insensitive to the economy of what it is we do, and we certainly do waste a lot of money. But if you're in an operating room and your chest is open and they're doing something to you and you have to be there, the cost of us being there versus the cost of the pump versus the cost of all the other stuff that's in there, it's such a small slice that to me it just doesn't make sense. And I think, again, at the very least, prime the pump. If it's me, if my family's having surgery, if it's me having surgery, I'd rather you handle. That's just me personally. That's how I feel for the ultimate in safety. Maybe that doesn't make sense in most circumstances because it doesn't happen that often. But man, every time there's been a problem, it's always chaotic. It's always a scramble. It's always a rush. Everybody's, you've got the scrub nurse who has to take the lines from us. You have a major bleed that's taking place. You have the surgeon screaming for the lines. The nurse, what's happening? What's child? Oh, that's good. Bring them in your lap. Or is you bringing your drink?
Say hi. Emily, come say hi.
Give her some alcohol. That's always good.
Say hi.
Hey, you're on the air.
Tell them what you want to do for a living when you grow up.
I want to be a mom, and I'm going to be I'm gonna be a mom.
A mom? Okay. You don't want to be a perfusionist. At least you're smart enough to know better than to do that. Okay.
A doctor too.
Good
Perfect.
for you. There you go. A doctor. Very good. Very good. So,
Sorry, yeah.
yeah, so it's always going to be chaotic. So they're bleeding. They need suture. They need clamps. They need this. And we have to get our lines up. So we're
Right.
standing there with the lines exposed, wanting them to take the lines, but the surgeon needs a clamp, needs laps, needs something, and you're trying to do all these things at one time. It's always a chaotic circumstance, and to me, it just makes more sense to just have it there and ready. It's right there already. You don't need
Right.
it, fine, throw it out. The cost as far as like I said, the cost compared to the cost of everything else combined is nominal. It's an insignificant amount.
Right.
And we're there anyway. They're paying for us, and we're a
Exactly.
lot more expensive than the thing. So get
Agreed.
rid of us too. Doesn't make sense.
Don't say that too loud, because if he's watching, the surgeon we were talking about, he would probably do that.
Go ahead. Go ahead. Don't call me when you need me. Okay? I'll be busy. All right. So, with that said, I think what we're going to do is we're going to take a 5-minute break. Nate, I know you've got some family responsibilities. I can't thank you enough for going ahead and joining tonight. I'll let you get back to your kids and taking care of them and being a good dad. And I don't know, go feed them, get them ice cream, and whip them, and put them to bed and make them go to
Thank you,
bed.
Joe.
You're welcome.
Thank
You guys take care. Thank you. And we're going to go ahead and take a 5-minute break, come back, and go to the second part of this about natural disasters.
Hey, Joe,
Yeah.
you got this urgent letter from the ABCP.
Oh, wow. I wonder what this could be. To Joe Basha from the ABCP. Wow, this looks official. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion is advising you that you must submit 10 Category 1 CEU by next week or you will lose your certification. Sincerely, Dave Matthews, PhD, Roger Ramirez, PhD, and the executive co-directors. Let me call my immediate supervisor, Stephanie, and ask her if I can go. This is perfect.
Hello?
Yes, Stephanie, hi, this is Joe.
Hi, Joe.
Stephanie, I just got an urgent letter from the ABCP stating that I am 10 CEU short, and I've been looking at this New Orleans conference, and I'd like to submit my request to go to that because I really need the credits.
Geez, Joe, I'm sorry I'm not going to be able to help you. Administration informed me they're denying all meeting requests. I guess you're going to have to find another way to get your CEUs.
Oh my God.
Hey, there's nothing I can do. You're on your own, Joe. Sorry.
I'm taking this up the chain of command.
Come in.
Dr. McGilvery,
Hey, Joe.
thank you for seeing me. I don't know what I'm gonna do. I do not have enough CEUs to maintain my certification.
Joe, how's that my problem? Our role is to pay you to do perfusion, not to pay you to go take courses. And it was that way in the past, but we just don't have the money to do it anymore. So you're gonna have to figure it out on your own.
Joe, what's up? Dr. Lumsden, I do not have enough CEUs to maintain my certification, and I'm gonna lose my certification.
If we can take all the perfusions away, we can't do any cases. We don't have enough perfusionists. I don't care about these CEUs. Costs too much money. You got to stay here and do these cases. Figure out some other way you're going to get education.
Hey Joe, you received another urgent letter from the ABCP.
Oh, thank you. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion regrets to inform you that because you lack enough Category 1 CEU, your certification is suspended. You are no longer a certified clinical perfusionist. Oh no. I really want to go to this meeting.
Hey Joe, you received a letter from your job, man.
Hey, dude, thank you so much. Dear Joe Basha, the Health and Happiness Hospital regrets to inform you that because you lost your ABCP certification due to a lack of Category 1 CEUs, you are fired. You must report immediately to the operating room and clean out your locker to make room for your replacement, who clearly knew more than you about getting CEUs and maintaining their certification.
Hey.
Okay, and welcome back to the program. Thanks very much for that short break. And we're going to press on and move right into our next talk. And we're going to talk about this especially in lieu of what is happening right now in, I think, around Williamsburg, North Carolina. I'm going to show you a little later on the most current satellite map about what's happening. And as you all know, last year we had Harvey occur here in the Houston area. And I want to talk about what we went through and what I personally experienced, as well as some of the things that some of my colleagues did. Now, I have to give Deb Adams and, oh my gosh, I can't remember the name of her student now, who actually put this presentation together for us at the New Orleans conference last year in June, or yeah, this past June, not last year, but this past June. And they did a phenomenal job with it, but the information is still very relevant, and this is an enormous problem, a huge problem. How do we, as healthcare professionals, deal with a natural disaster? The natural thing to do is you want to take care of your family. That's what you want to do. But yet we have this oath and responsibility to care for patients. And it's a tough one. And I'll tell you a little bit more about some of my experiences and some other people's experiences here in Houston, which are just amazing. I mean, even some of the folks that work for our group, their homes were inundated by water and they were essentially homeless. And the insurance company and FEMA and whatever else, they don't respond nearly as quickly as they may show you on television. It's not until later when you find out all the trouble people are having and they're displaced. And if they don't have enough money, it's really a problem. It's really a big problem. So let me go through some of these slides. I think they're very interesting. So Hurricane Harvey occurred a year ago, August of 2017. Was a Category 4 hurricane at landfall on the Texas coast, and it landed actually quite a bit south of Houston. Houston did not experience much of a wind event. Mostly what we had here was rain, and we had 4.7 million people in Houston and Harris County directly or indirectly impacted due to flood and receding flood waters. So both as it's coming in and then going back causes quite a bit of damage. Water movement, when water moves, it moves with tremendous power. Here's a picture of some folks being rescued, and you can see there that they are essentially surrounded by water. There is no way out except for this rescue helicopter. Parts of all 22 major freeways in Houston flooded and were impassable. And if you look at this picture right here, that is the same road. Right here, East Freeway, and that is the same road. There's downtown that you can see, and you can see this entire area is completely submerged. It perhaps was not as bad as Katrina, but it was awfully close to it. Katrina was devastating. It was horrific. And some of the stories that came out of New Orleans about them taking turns and shifts at handbagging patients until exhaustion and not being able to do it. I mean, think about the trauma that would occur at some point when you cannot continue to do something like that, and and the patient is completely dependent. That's a horrible thing to think about. We didn't get like that here, thank God, but it probably wasn't that far off because it was bad. I'd never seen so much water in my life. Over 300,000 vehicles flooded in Harris County. Over 200,000 homes flooded. The Texas Medical Center, if not the largest, one of the largest medical communities on the globe, flooded. Memorial Hermann Hospital, the entire first floor flooded up to the stairwell. It was a big problem. People couldn't leave. People couldn't get in. People that weren't there, if they had a ride-out team, they weren't leaving. You weren't a ride-out. That's the ultimate in ride-out teams. Huge, huge problem. This is the street of an on-call perfusionist. They aren't coming in. $125 billion in damage. The second costliest hurricane in American history. And keep in mind, I'm going to show you an image here in a little bit of what Florence is about to do. And my heart and our hearts should be going out to all of our colleagues in the medical community right now who have to stay behind because they're in healthcare. And it's a moral dilemma. I'm going to talk more about that, but and we got to have that discussion. But it is really a big problem. This was considered to be a 1,000-year flood. 4-day rainfall totaled 51.8 inches of water, of rain, recorded in the greater Houston area. A total of 1 trillion gallons of rain fell in a 4-day period. I have never experienced that much rain ever. I mean, it was, I just, every day, I would go to sleep to the sound of torrential rainfall, and I would wake up at various times throughout the night until the morning to torrential rainfall. And it would come and go in waves. You would think, oh my God, it seems like it's lightening up, but it was only a brief respite, and then it was like there was a waterfall coming out of the sky. It was the most unimaginable thing I've ever experienced. Rainfall amounts and spatial coverage never experienced in the U.S. before since they started keeping records. So the most rainfall ever recorded. 50,000 square mile area, Harvey rainfall, 16.6 trillion gallons of water, enough to supply the entire U.S. water need for 280 days. 3/4 of a year of all the water used in the United States fell in 4 days in the greater Houston area. 275 trillion pounds of water. I mean, when you look at those numbers and think about how much water we're talking about, and it fell out of the sky, which was the strangest thing, because it didn't come in as a storm surge. We're talking about rainfall. You know how rain usually falls in drops? There weren't any drops. They were sheets of rain pouring out of the sky. So how much is a trillion gallons of water? Enough to cover Harris County's 1,777 square miles with 33.7 inches of water. And this volume of water could run Niagara Falls for 15 days. So think about, now 4 days is all it was. So think about Niagara Falls, how much water is cascading over that edge, how much water that is, but all in 4 days. So you have to multiply that you have to 3 times that amount that you see at Niagara Falls, because that much water fell in only 4 days. That's the thing that's so incredible about this. It happened over just 4 days. So there are a multitude of natural disasters that we have to deal with. There's earthquakes, there's floods, there's hurricanes, there's tornadoes, there's windstorms, there's volcanic eruptions, and there's wildfires. In California, they're experiencing that. All of these things create major problems for any one individual, but also as a community, healthcare professionals. Because again, our instincts are to take care of our family, but our responsibilities are to both. Certainly we have that responsibility to our family, but we also have this responsibility to the patients. What do we do? It's an ethical dilemma. Some people may feel very strongly, say, you know what, my family comes first. Too bad, so sad. Sorry you didn't make it, not my problem. They're gone. Some people are like, look, let me send you guys away, get you out of here if possible in advance, but I've got to stay behind. But sometimes it happens so quickly, like an earthquake or a tornado or possibly even a wildfire, volcanic eruption. You don't ever know when that's going to happen. So there are some circumstances where your family can't get away. None of you can. Do you stay with them if they're safe but displaced and go to work? Or do you stay with them and get them completely out of there? How do you manage that? I wish I knew the answer. And I wish somebody would call in and tell me what their thoughts are, because I've certainly got opinions, but I don't know how I would exactly react. If I knew how I reacted in this circumstance, my family was safe. But if I had a different situation, like our previous guest earlier in the show, Nate, and he's got 2 small children at home, is it the responsibility of those people who have the luxury, let's say, of not either having their family in the same location to step up and go to those circumstances so that people with families can take care of them and not have to do it? I don't know the answer to that either. I wish I did, but I don't. I'm curious what other people think about that. Impact of hurricanes and floods on health of the community. Well, injury and death, medication loss, unsafe food and water, respiratory illnesses, all these things happen quite commonly. Skin diseases, of course, rashes, and they can get infected, cause sepsis, have problems. Psychological related stress, could you imagine hammering your way out of your attic barely or worse, not being able to save someone that you hear on the telephone calling, begging for help, that can't get through the roof, and they drown as the water continues to rise? That really happened. That actually happened, and they were on the phone asking for help, and they couldn't get helped, and they died still on the phone. That's horrible to think about that. Gastrointestinal illnesses, of course, are going to happen because you're going to drink some of that water, contaminated stuff. It's going to get in your mouth, even if you're not intending to drink it. It's going to happen. Finding food can be quite difficult. Look at what's happening in Puerto Rico. That place was decimated, and a lot of those places were isolated. That was a huge, enormous problem. And I'm not faulting anyone. I mean, not at all. I mean, this is not a criticism in any way, shape, or form. But a colleague of mine down there, somebody called up and said, you know, you need to come into the hospital and you need to stay here in the hospital. And he said, is the surgeon going to stay in the hospital? Well, no. And he said, well, I'm not staying in the hospital either. You know, and I can't blame him for that, because that's another issue. Is his responsibility is as a perfusionist. He's one of our colleagues. But does he have a responsibility as a healthcare professional? Does the physician, a physician of all things, have a responsibility as well, maybe even a greater one, to have gone and stayed in the hospital? Because those few physicians that get left behind, those few nurses that get left behind, that are there for extended periods of time, how long can they work for without a break? And you don't know when you're going to get back. You think you do. Oh, it's going to happen, it'll end, it'll be over, we'll be on our way, we'll get back, until something like Harvey happens, until something like Katrina happens, or something like Florence is about to happen. These are serious questions, serious concerns. Again, curious what your perceptions of that are. Challenges for the healthcare system. Initiating a response. What if the facility itself becomes damaged? I was up in Northridge, California when the Northridge quake happened, and the hospital actually was condemned, but there was a patient that actually needed heart surgery, and we did heart surgery and used bottled water because the water in the sink wasn't working, and poured water, bottled water, to wash our hands with. The surgeons used that to scrub with, and that's what they did. Patient and non-patient surge. So you're going to get, not only is your facility damaged, but now you're getting more patients that you normally would get. Staff shortages because everybody didn't come in, and now they either can't get in or they're not coming in, whatever the circumstance may be. Medical supply shortages, of course, are going to happen. Food and water supply shortages are going to happen, even in the hospital. Now you have people that may be trapped. You have patients. People need to eat and drink water to survive. So here you are in a hospital. You need these things and you can't get them. Security. People walk in there, crazy people. There's a lot of crazy people out there come into the hospital because that sounds like a real easy place to go steal from, or whatever the case may be. They might even just be there trying to save themselves. You know, who knows? They just have nowhere to go. Loss of city facilities vis-a-vis emergency response, police, fire, ambulance, so forth, and loss of communication networks. Look, I mean, there were hospitals. What happened in Katrina with Charity Hospital, where the generators were in the basement, and the basement flooded. So now they have no generator power. They lost everything. The generators weren't on the roof, they were in the basement. So that was it, they had no power. Healthcare professionals and personal preparedness response skills for disasters. Well, there are professional skills and expectations. We all have basic medical skills well beyond that of the normal non-medical person. First aid skills and training, we can deal with a lot of things. Regardless of whether you're a nurse or not a nurse, you can follow directives and do a lot. Working without technology, you have to be adept at doing that because the computers aren't going to be working, so that's going to be down, and you need to be able to deal with that. So millennials, you're probably going to have a big problem with that. There needs to be the development of a team emergency action plan, family emergency plan for your own family, and disaster training. We just simply do not do enough of that at all. Something that needs to be done. And how do we prepare for stress? You know, PTSD after these events is common. So what's the source of the stress? Work. Recognizing signs of stress. Look at any healthcare professional. Burnout. We're all burned out. Healthcare providers who are disaster victims themselves. Managing that stress. And emotional resiliency and disaster response training. So you have to, I think if you prepare, if you're better prepared, then you're going to be able to deal with the stress a lot better, and your ability to maintain your emotional composure during these crisis situations is going to be much better. But the reality is, we really don't do these things. And it's something that I think especially those of us on the coast with these hurricanes, but I think other people as well need to start taking this more seriously and dealing with it, especially when you're, let's say, like we are, a private group in a community hospital servicing multiple hospitals. We can't put a person in every hospital. We don't have enough people to do that. Simply can't do it. It's impossible. You're in the med center of Houston, Texas. Like I said, either the largest or one of the largest healthcare communities in the world. There's no way they could have enough people to manage everything that's going on down there. So there's going to be skeleton crews during these disasters, no matter what. And if we're not prepared for it, if people don't know who's coming in, there's additional stress of finding people that will come in and ride the storm out or deal with the crisis. We don't have a plan. And I think that's what I'm trying to convey here is I think we need to all be thinking about a plan and what is our responsibility. How do we do this? Perfusion education and emergency preparedness of the perfusionists included in the ACPE consensus curriculum for perfusion training at an accredited program. So, interestingly enough, new students are now trained on crisis managing emergencies, disaster preparedness or emergency preparedness, interventions during a disaster, massive transfusion and autotransfusion, emergency ECMO support, transport of patients on VAD or ECMO. So there's a lot of things that may need to happen. For example, you got a patient on ECMO at hospital X and that hospital is falling apart. You're going to have to get some of these patients out of there. How do we have enough helicopters? How do we have enough people to go on the helicopters to manage the ECMO, to get the patient to another facility that isn't affected by the situation, or transporting patients on VADs? These are things we need to be able to think about. Let's say there's a patient on ECMO in another hospital and you're a perfusionist somewhere else and can get to that hospital, and you're the only one that can get to that hospital, but it's not your patient. Now, how are you going to get privileges there? Got to deal with that. Will your insurance cover you? Got to deal with that. Got to figure out if you can get to the hospital, because there may be a perfusionist in there who he can't stay up 24/7 for the next however long. He's going to have to get some sleep at some point in time, and this could turn into a problem of the thing needs to be hand cranked because the power goes out and you're trying to figure out what to do. Well, he certainly can't do that by himself either, he or she, as the case may be. So I think that there's a lot of opportunity here for us to think about what we can do, how we can better prepare for these emergencies. And what I'm going to do now is I'm going to just very quickly, we're just going to take like a 1-minute break. Make sure you got the phone lines open, and I'm going to come back and we're going to try to answer some questions that may be on the YouTube chat, and we're going to see if we can get some calls to come in. But give us just about a very quick 2-minute break, and we're going to come back and continue to discuss this.
Hey, Joe.
Yeah.
You got this urgent letter from the ABCP.
Oh, wow. I wonder what this could be. To Joe Basha from the ABCP. Wow, this looks official. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion is advising you that you must submit 10 Category 1 CEU by next week, or you will lose your certification. Sincerely, Dave Matthews, PhD, Roger Ramirez, PhD, and the executive co-directors. Let me call my immediate supervisor, Stephanie, and ask her if I can go. This is perfect.
Hello?
Yes, Stephanie, hi, this is Joe.
Hi, Joe.
Stephanie, I just got an urgent letter from the ABCP stating that I am 10 CEUs short, and I've been looking at this New Orleans conference, and I'd like to submit my request to go to that because I really need the credits.
Geez, Joe, I'm sorry I'm not going to be able to help you. Administration informed me they're denying all meeting requests. I guess you're going to have to find another way to get your CEUs.
Oh my God.
Okay. There's nothing I can do. You're on your own, Joe. Sorry.
I'm taking this up the chain of command.
Come in.
Dr. McGilvery,
Hey, Joe.
thank you for seeing me. I don't know what I'm gonna do. I do not have enough CEUs to maintain my certification.
Joe, how's that my problem? Our role is to pay you to do perfusion, not to pay you to go take courses. And it was that way in the past, but we just don't have the money to do it anymore. So you're gonna have to figure it out on your own.
Joe, what's up?
Dr. Lumsden, I do not have enough CEUs to maintain my certification, and I'm gonna lose my certification.
We can take all the perfusions away, we can't do any cases. We don't have enough perfusionists. I don't care about these CEUs. Cost too much money. You got to stay here and do these cases. Figure out some other way you're going to get education.
Hey Joe, you received another urgent letter from the ABCP.
Oh, thank you. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion regrets to inform you that because you lack enough Category 1 CEU, your certification is suspended. You are no longer a certified clinical perfusionist. Oh no. I really want to go to this meeting.
Hey Joe, you received a letter from your job, man.
Hey, dude, thank you so much. Dear Joe Basha, the Health and Happiness Hospital regrets to inform you that because you lost your ABCP certification due to a lack of Category 1 CEUs, you are fired. You must report immediately to the operating room and clean out your locker to make room for your replacement, who clearly knew more than you about getting CEUs and maintaining their certification.
Hey.
Okay, and welcome back to the program, everybody. And we've got our phone lines open. And while we're doing that, we're actually monitoring right now. Is it possible to cut to the current the current radar or the current satellite to what's going on while we wait for a second to see if somebody calls and what's going on with Florence? Oh, here's the phones. Hey, Min, you're on the air.
Hey, how are you guys doing?
Doing good. We're doing great. Thanks for calling.
Absolutely.
Hey, so back when Harvey was going on, you were here working, and I know that we all had a lot going on, and you actually had to get to a couple of hospitals because of various emergencies. Even one there was like a gunshot wound that went to one hospital, and then a couple of patients in the cath lab that they needed emergency support for. What was that like for you?
Well, at first it was a little stressful, honestly, because getting called in and then trying to navigate and figure out a game plan on access roads and where I could get to and how safely and quickly I could get there to help the patient or help whatever they needed me to be there for.
Mm-hmm.
So it was definitely something that I had to kind of plan ahead to figure out a game plan on where I could go, what roads I know that may still be accessible for me. So I actually took the time initially each morning when I had a chance to get out on the road when the weather wasn't too bad to assess the highways and the roads and kind of keeping up with the news and just updates on road closures. And it was scary though, because I even though in a truck, I could easily get somewhere and be stranded or stuck, and with no access to get back home.
So you had a big truck.
I did. I had a truck.
Yeah, me too. And that definitely does help. But
absolutely.
We had one facility that wanted a perfusionist in house. Now we went to hotels and we hung around hotels during the height of the storm that were essentially within swimming distance of the hospitals. If we had to do it that way, because a lot of the roads were closed, we could not get through. But I think we were very lucky because we have people living in so many different areas of the city that are closer to their respective hospitals. But there were some hospitals too, in fact, that were completely impassable. In other words, no one could get in or out of those hospitals.
Right. Yeah. That's definitely something that aided us in that situation when we needed some support, because being that we're being with the emergencies and not knowing what access roads we would be able to get to, that definitely would play a part in making sure that you have personnel and people readily and able to meet the needs. Because in addition to just patients possibly getting admitted to the ER, our typical day, someone get admitted to the ER with chest pain, we have patients that have possibly been in house who have come days previously before the storm and gotten admitted and could have been there waiting for surgery, and something happens or whatnot, and they go for a cast, and just, there's so many different scenarios that could bring a patient our way and definitely need us to be there ASAP.
Yeah, well, that's a very good point. But looking at the for example, the one perfusionist. And again, I am by no means criticizing anybody for whatever decisions they made, their own personal decisions, because I just simply don't. I think that some of these disasters are so horrible, and yes, we have a responsibility, but you've got a family and your family is in peril, and how do you leave them to go over there? It's a very difficult situation to be in. But I've heard the argument, well, if the surgeon's not there, then why do I need to be there? And unfortunately for us, we can put patients on ECMO without a surgeon. We can't put the cannulas in, but a cardiologist, if there's a cardiologist there, certainly can. An emergency room physician, if they can get access and know how to do it, can do it. So, you know, what do you do? How do you manage that?
That's that's very true. I guess, you know, you can't just go on the basis if the surgeon's not going to be there, then we're not going to be there. And I mean, absolutely. I mean, it's kind of like we getting called for a gunshot wound. If the patient gets a thoracic gunshot wound, then obviously that's, you know, we'll need a CV surgeon. But of course, you know, a general surgeon or ER doc is going to have to manage and do what he can until that person can get there. So, yeah, being that said, that does definitely not omit us from having to be there. But you make a good point on, yes, you know, we have to worry about the safety of ourselves and our families.
Yeah, absolutely. I mean, men, where do you draw the line? I mean, look, it's a good, I mean, where do you draw the line? When do you say that I am either going to or I am not going to risk my life to get to that place for that patient? When do you make? How do you make either of those decisions?
I think you would just have to use your best judgment on what kind of, I guess, a plan that you have with your team with in an emergency situation like that, because, you know, you have to know what people you have in one location and what hospitals you can get to, and like you said, you know, when do you draw the line? I think as a person, you know, as a, you know, perfusionist, and we're, you know, obviously, you know, we're all committed, you know, and licensed to do what's best for the patient and be there because that's what we committed to as our job title. But at the same time, I think we definitely have to make the best decision and judgment based on if we think we can get there. I mean, obviously, every situation or scenario could be a 50-50 and could go wrong in any disaster, because you never know what you may run into. You could run into high waters. You could run into debris on the road, power lines, you know, impeding us from getting to where we need to go or getting back.
Right.
So, yes, that is a very hard question to really answer. And I think it's something that we have to just take upon ourselves and make the best judgment, knowing our scenario and our situation. And if we think we can make the trip and be there and do what we can to get there, I think it comes down to, you know, the situation, your area, if you know it well enough to know that you have access, and if you for sure you don't have any access, and you know definitely from the news and data that you've seen that things aren't open, then I mean it's definitely something that I wouldn't want a colleague of mine to risk, you know, his life to go do. And I mean it's I wouldn't know what to say or how we would handle it if something happened, you know.
Yeah, that's a very good point. Let me ask you this, if I can. Would you how do you think that, let's just use our group as an example. Do you think we should have a plan, and that plan is those folks who don't have small children, those folks that may not have families nearby, or smaller children families nearby, that when it comes to our disaster protocol, those people are preferentially or differentially the ones that are on the list to be first to go in? Or should it be that there's a disaster looming, you know it, as opposed to a more acute event, something like a big storm coming. And if it's your turn, there's some rotation, then it's your responsibility to have your family leave town so that they're safe, and that is not an additional distraction. I mean, which one of those two, how do you do it fairly? Should it be the older people who have less energy, who can't, it's funny, I know, but it's true, can't, work as hard, get tired, you can hand crank only so many hours, but a younger person can do more, but their life is more sacrificable. I don't know, I'm thinking just crazy, but whatever, I'll throw it out there. Or do you say the younger people have that responsibility, the older people have already been there, done that? How do you balance all of that and make it so that it's fair? Because I can tell you right now, not every older person is going to want to stay behind.
Right. Well, you I mean, and of course, you can't say that it's fair to put the young people at risk, because that means young people probably have young children at home, and if something happens to them, then their kids, their kids could be fatherless or motherless, if something, God forbid, happened.
Yes, good point. I mean, look, it's true. That's a really good point.
It's a double-edged sword, and I think what you mentioned before, in a way where some programs and institutes have a protocol evacuation or emergency plan. That is a great idea, and I think that's something that most places use, and that's something that we've used. Like when I was a respiratory therapist at Oshers in New Orleans for Katrina, I was in Katrina. We had a plan, A team and a B team, and me not having any kids, and all I had was a girlfriend and a couple of dogs. I was part of the A team. I volunteered to be the A team, and I stayed, and other people who had families and animals and children and whatnot needed to evacuate. They did, and we stayed, and we hunkered, and we kept the house going until the storm passed, and then the relief team was able to come in to get us out, which was about a week later.
Holy mackerel!
Yeah.
So you've been through two. You've been through Katrina and Harvey.
I have. I've had my share.
Yeah, you have. There's no question about it. I mean, I think that, okay, so for us, should we be discussing this now? Should we, in other words, that A team and B team you were talking about, was that prior to the storm forming in the Gulf, or was that something that happened as a result of that big storm that was brewing? Because everybody knew this is coming.
That was something that we've already, the department already had a protocol in place, and it protects everyone. It keeps fairness and obviously being in New Orleans, and in the South, we get hurricanes every year, multiple hurricanes. And we never know which ones are going to be bad, which ones are going to be good, which ones, we might be without power. So, even though if it's not a storm or we have to evacuate, there's still instances where a hurricane may come and we may lose power. And in that case, if you have some people who have families at home and they need to attend to them, maybe they might be caring for an elderly person, a mother or father who might be disabled, things like that, and they're at home, and God forbid they're on some kind of support, and need power and whatnot, then obviously those people would definitely need to be part of the A team, and it's kind of one of those things that we would volunteer and rotate, and if someone has special needs and they always need to be part of the B team, then we make that happen, and we work as a team, and that's what we do at the end of the day. We have to work together and make it happen, and
to make it fair.
Exactly.
So it was sort of voluntary. Well, Silent Scope 1032 on YouTube says, and I don't know if it's a girl or a boy, I don't know who it is, but each person with the same job title have the same responsibilities, old or young. So that's their take on this. So, and I sent back a question to Silent Scope 1032. How do you manage disasters? So, Silent, if you're in there and you're watching, please don't remain silent, because I'm curious, how do you deal with this? Do you have a plan already in effect? Do you just do it on a rotation? So this week it's Team A. That next week Team B is basically on the hook should something occur. And so I think that's a good question. So here, Silent Scope responded: a manager or a boss should not have an expectation of one employee giving more than another. Well, that's true. Okay, but how? But Silent, how do you manage it? I think that's really the question.
Right.
You know, I don't know. I don't know the answer. I don't know what the right answer is, to be honest with you. But I think that as a group, we separate from, of course, my colleagues out there in web world, I recommend that you additionally sit down as a group and discuss this, because the disaster can befall anyone. It doesn't have to be hurricane risk country like the coast, the southern coast of the United States, Gulf or Atlantic. It doesn't have to be California with wildfires and earthquakes. It doesn't have to be Oklahoma with tornadoes. It can be anywhere. So blizzards, happen. I mean, anything can happen. So you just don't know. And if you're in that situation, what is the plan? You have to have a plan. And right now, I don't think we have one. Fact is, we don't have a plan. And I think we need one, because this hurricane season, look, our memories are horrible. Harvey it was just a year ago. And we're all, here we are, we don't have a plan.
Right. And definitely, we should be proactive. We should have a plan set in. And because you don't want to wait till the time comes and then so-and-so, can't do it and this and that, it should be set. And, once we have it set, then we all know what we're committed to. And when that time's come, then everybody's going to be expected to pull their weight and play their role, their position on whatever team they're listed on. And granted, if there's a specific issue on why a reason they can't do it, then, that's just something that they would have to work out with the team. But I think at the end of the day, it's something that everyone should set into play and create a protocol to protect us, protect our group, protect our name, protect our license, and protect our reputation for what we do and who we are as perfusionists and our responsibilities. And at the end of the day, we also need to look out for ourselves, because no one else will. At the end of the day, we have to take care of each other.
Yeah, I agree with you. I think, I think all of those are very good points. And I think that, Silent Scope, whoever they are, has a very good, has some good thoughts, and that being that a manager should not have an expectation of one employee giving more than another. I mean, I think that's probably true. But, I do think, of course, I view it perhaps a little differently. I feel like the manager should be the person, one of the people that stays behind. I think that's what your role dictates, regardless of what's going on. When Harvey occurred, and I'll give myself a pat on the back. I'll do both sides. I could have bailed and gone to Alexandria, Louisiana, and been high and dry the whole time, but I didn't. I stayed here. I got a hotel by the hospitals, and I was part of the team in the process of what needed to happen. Because I don't believe, in adding to Silent Scope, I don't believe that a manager should expect something from their team that they themselves are not willing to do. That's what I consider to be leadership. That's a leadership issue. But that happens, probably not too infrequently. However, with that said, it didn't happen here, and I'm proud of myself for that, and I'm proud of everybody else that's, in our group that stepped up, those of us that did step up and deal with this very, very big problem, because it was a very, very big problem. And it could have been a lot worse. I think we were very lucky in a lot of ways because it could have been far worse than it actually was. So I think we dodged some bullets as far as that's concerned. But I do think that we do need to have a better plan. I think you bring up some very good points. Regardless of what method we use, I do think we need to come up with a decision soon, within the next couple of weeks, of how are we going to manage a major catastrophic event, whether in both ways, one that is perhaps predictable and one that is not predictable, and figure out how we're going to do that. Because you're right, we don't have a plan, and we need one.
Right.
And everybody else needs a plan too. I think this is not something that's unique to us. I would dare say that I don't think most people do truly have a plan. I think some do, and we need to learn from them, and we need to get one ourselves.
Right. Absolutely. Absolutely.
Well,
at the end of the day, it's going to save us. It's going to save. It's going to help everyone out, and we will know what we need to do and what actions we need to take to be there, and if they need us, and get to where we need to go.
Right, and of course, if you have it already, everybody already knows what the expectations are. You're not scrambling and having to either ask or then demand or direct order people to do something. Yeah, I think when you do it in advance, then look, this is what we've decided on. It's a lot less of a problem.
Mm-hmm. I agree.
Okay, so can you stay with us for a few minutes? I want to show everybody something. I'm going to go over to our weather map, and I want to talk a little bit about what's going on right now in Florence. And again, I started the program off with this, and I'd like to end the program with this as well. A little bit of brevity as well, just have a little bit of fun, but also before that, the seriousness of what is actually happening. We do have a lot of colleagues in the North Carolina area, and they are currently, in an emergency, dangerous, and treacherous situation where they're getting pounded by a very powerful storm. And I think that we all need to say our prayers for them and hope that they do well through all of this, and that the damage is minimal and loss of life is non-existent, I hope, and that our healthcare professional colleagues are able to manage all of the problems that may occur, that they don't have that many problems to deal with, but those that they do deal with, they're able to manage very well. So let me go over to the weather wall, and after we take a look at that storm, I'll show you a video just to lighten the mood up a little bit and say goodnight to everybody. So we have the storm on the, yeah. So here's the storm here that you see. Here, let me come over on this side. I think you can see it better. So there's the storm, and there's Wilmington, North Carolina, which is going to get hammered by this thing. And this is a pretty good sized storm. It's, I think they did downgrade it to a Category 2, but be that as it may, it's still a powerful hurricane. And I hope that everybody in this area does well. So that's what it looks like right now. Our thoughts and prayers are with all of you over here being affected by this, and I hope you all do well. So let us know, hopefully through YouTube or Facebook or something, that everything has turned out okay. So our prayers are with you. But just to show you a little something more about what happened to us here in Houston during Harvey, I'd like to show you this video on YouTube, and listen very carefully to the reporter.
Focused and knows how to do kind of two things at once here, because he does it with us for a living. But if you are in the process of being rescued, please pay attention and stay focused. This is a lot happening. It's a lot of stress. Even if you're feeling out of control, the person next to you might be. Might not. And that was really an example of what we're seeing here. Look at them sharing water just out of the cap of that bottle. It's fantastic.
Yeah, I'm not sure that was water.
Well,
But
Whatever they need to feel better, guys.
Okay.
Now watch again. Watch again. You're going to see
we'll continue.
they're on the boat, and there's the girl walking.
If they should, we'll monitor Bill's video, and if they should.
But there's Koki, and there is the water.
Thank goodness for that.
So just so you know, Magic, who is our Polish connection, he knows Koki. And Koki, he isn't Polish, but he's within, I guess, the Polish mafia. And so that was actually vodka. And let me tell you what, I have spent almost the last 2 hours talking. And yes, I am very thirsty, Magic. I'm very thirsty. Yes, so we're here in Houston. We're now suffering. That's good. That's good. Here's to our fellow healthcare professional colleagues in North Carolina. Hope you do well. And in honor of Koki. Oh, that was good. Okay. Good night, everybody. We'll see you October 2nd for our next program. But the program that is really going to be neat is October the 4th. Patrick is going to be here with us, and he has this project of having 5 cameras on everything about the heart-lung machine, the operation, the hemodynamic monitors, everything coming in, and all put on a single screen so that you can see everything that's happening during the procedure. When the coronary is bleeding and you turn the vent up, watch the coronary clear. When you give Neo, you see the pressure go up, you see the flow go down, you see the volume come up. When they pull the heart over, you see the volume go down, the flow come down, the heart distending, the pressure come down. Everything that happens during a case from the beginning to the end, when you come off bypass, going on to coming off, you'll have an opportunity to see, and it is really, really, really interesting. So make sure you tune in on October 4th especially, but don't forget also for October 2nd, this program was approved for 2.5 ABCP Category 1 CEU. I'll be sending the survey survey monkey evaluation out tomorrow for the program on Tuesday and this one. So you'll get that and should get your certificates by early next week, Monday, Tuesday at the latest. If you get those surveys into us, as soon as we get them, we send the certificate out. And I'll look forward to seeing all of you on October 2nd. Thanks for tuning in tonight. Hope you enjoyed the program. Despite we had some technical difficulties getting started, and life is always going to be like that. The program is live. You got to love live TV. But call in more, chat more. I so much appreciate our chat today and our call in. Do it more and help make this program really great. So thank you all very much. I bid you good night till October 2nd.
Hello, this is Stephanie with HET Perfusion. Oh, okay. We have an open heart 1 month from today, 9 a.m. start. Oh, really? A single vessel off pump? No problem. Thank you. can you bring me a sandwich? Oh, thanks, Mom. You're the best.
You having a rough day, baby?
Oh, working for HET. So hard, huh?
Stephanie, go on the pond.
Okay.
Is that better?
I'm like smiling now.